As you all know that we are discussing an interesting case of vesicovaginal fistula. The case became too long because we wanted to discuss small little practical points. So what we have done, that we have divided the first visit part till evaluation, history, examination, evaluation and making a diagnosis part in part one.
Yes,
If you
ma'am.
have not yet watched it, I strongly suggest that go and see that part. And now in this part we are going to discuss how we actually managed.
Yes, ma'am.
What was the treatment of it. So I'll just to recapitulate, this patient came with vesicovaginal fistula. There was single fistula and
Yes, ma'am.
fistulogram, CT fistulogram we did. We identified the tract and then we sent the patient not for any antibiotics course or not for anything, because we were just waiting for the next good date
Yeah.
for her, because it is not such an emergency that we have to admit the patient
Right away.
today
Right,
only
ma'am.
and do
Right.
it like cesarean and fetal distress.
Yeah.
We can send her home, let them arrange, let them get
Yeah.
prepared, let them come with some money, whatever they want to come to a different city, get admitted. Let them come with the mindset that they have to stay
Get
there for-
operated. Yes, ma'am.
So all
She
these
also built her
preparation-
hemoglobin in that time. Yes, ma'am.
That's how we finished the case, that her hemoglobin had
Yes.
picked up. It was 10 point
Absolutely.
something. So all these preparation we did. But the earliest possible date, we cannot
Yes,
keep them
keep on
waiting
delaying.
for long.
Yeah.
So patient came for after around a month for her surgery.
Yes, ma'am.
Now we have planned her surgery tomorrow, suppose, though we have
Right.
already done it.
Yes, yes.
So
But-
suppose this is the day of surgery, everything patient is fit for surgery,
Yes.
anesthetic checkup has been done.
Yes.
So how do you start it? First thing, what will you do, Sufrit?
We did a cystoscopy, and in the cystoscopy, we had done a ureteric catheterization or stent placement.
Yes.
And
For both the ureters?
Yes,
we
right,
placed
for
a
both the
stent.
ureters. Yes, and we also placed a stent along the fistulous tract.
Yes.
Yes, ma'am.
And how do you place? So we have to delineate the tract
Right,
also,
right.
so the dissection becomes easy. Actually, it is very, very important where the fistula is very small. Okay?
Yes.
We are worried that when we open the abdomen, we might not be able
Miss
to see
out on
the
it.
Ureteric, this
tract.
one, and the tract.
Not
Yes,
ureteric,
sorry, the
but
tract.
the
Yes,
fistulous tract. It was a very big fistula, but still we must keep on doing same practices what we do.
Mm-hmm.
So how do you put that stent? The easy way to put it
Yes,
is
ma'am.
that put a right angle from the vaginal
Hmm.
end to the fistula, and then through cystoscopy see
Right.
the clamp, end of the clamp,
Hmm.
that right angle clamp, and from urethra you put a thin wire. It can be any wire, it can even be a normal Foley's,
Right.
whatever you have available. It can be a Ryle's tube also,
Yeah.
whatever you have. You catch hold of this, and from vagina you bring out your instrument.
Yes,
So it is looped in the tract.
Right.
From the urethra, in the tract,
Yeah.
into the vagina. So the tract is well delineated.
Yes, ma'am. We used a very narrow stent and made a knot.
Yes.
Yes.
We can clip it or make a
Make a knot.
also.
Yes, ma'am.
Then patient is in lithotomy position.
Yes,
then
ma'am.
we open the abdomen.
Yes.
So these kind of fistula, do you want to do laparoscopically or laparotomy?
Ma'am, we should do a laparotomy in this case.
Yes.
It was a high fistula. It was a big
High
fistula.
is not the problem.
Yeah,
Maybe
very
high
large.
is
Yes.
laparoscopy is better.
Yeah.
But it was a very
Big fistula, long-standing
long-standing
fistula.
fistula.
Yeah.
So sometimes we are limited in doing when we do laparoscopy.
Yes.
The suture bites are good, but not as robust as what we can do
When we
by
are
an
seeing
open
it.
technique, when
Yes,
we are
ma'am.
feeling it and doing
Absolutely,
it.
ma'am.
Okay, so definitely, even if you want to do laparoscopy for
Yeah.
small fistula, for
Yeah.
bigger fistula, better will be a
Laparotomy.
Okay, because the risk of recurrence here, we should not think of when a patient has undergone a TLH. She has undergone laparoscopy.
Yes,
I will
ma'am.
say don't open her abdomen.
Right.
Okay,
Yeah.
because for the major surgery, you have given her 4 holes,
Yeah.
and from handling its complication, it is very bad that you have given her a big cut.
Oh,
Right.
yes.
Okay.
Yes, ma'am.
So those you should try your level best to do
To make it a
with minimally
laparoscopic.
invasive
Yes,
procedure.
absolutely,
But
ma'am.
here the patient is leaking for 5 years, big fistula, she already has a scar, patient is thin built. Why not do it?
An open
and
procedure.
see it.
Yes.
Yes,
So we
ma'am.
had put her in a lithotomy position.
Yes,
and
ma'am.
what incision did we give?
We gave a transverse incision.
Transverse
Yes.
incision. So now when you have to choose
Yeah.
whether you should give a midline incision for VVF repair or a transverse incision, which one would you choose?
Ma'am, we would choose a transverse incision
Transverse.
because it provides better exposure and all the organs that we need to deal with are clearly seen in that
Yes.
In the
incision.
We
pelvis.
don't have to do anything in the upper abdomen.
Absolutely.
Right.
Whatever we have to do, we just have to pull out an omental flap that you can put your hand and pull out. That's
Right.
not a big
Yeah.
deal.
Yes,
So
ma'am.
all organs, and if you remember,
Yeah.
this patient
Yeah.
had a very small distance between
Between
her
her
umbilicus
and pubis,
and
yeah.
pubis. So maybe if we wanted that kind of good exposure, which we got for our transverse incision, which we did muscle cutting or malar, we
Yes.
would have to
Probably
go
not
above
got
the
it.
umbilicus.
Yes.
Right.
Which
We
would
wouldn't have
been
gotten with an
hard.
infraumbilical
Yes,
vertical
because
incision.
the space there was very limited. So it was very good that we went from 1 ASIS, near 1 ASIS. We did not
Yeah,
get
near
damaged.
about.
So if you cut the muscle, if you make it muscle cutting, you always get a very good
Better exposure.
Exposure.
Absolutely.
Yes.
ma'am,
After
yeah.
opening the abdomen and layers, what did we do?
Okay, so ma'am, after opening, we placed the self-retaining
Retractor.
retractor, and we also placed a bowel pack to make
Yes,
the bowel move
in
away
the
from
upper
our weight.
abdomen.
Yes,
So
right.
our field was very clearly
Yes.
delineated. We wanted to see bladder. We wanted to see
The uterus, yeah.
So will you be putting the video in due course
Of course,
time?
very
Yes,
soon,
soon,
very
ma'am.
soon. Yes.
Keep on following us so that you get to see the video also. So now all the organs are delineated. Then we held the uterus with the uterine holding forceps.
Yes,
Right.
yes, yes, yes,
So
ma'am.
that we have some kind of traction.
Traction.
If you want, you can put a sponge holding forceps in the vagina and then with
Even
the sponge
push it,
holder
okay.
and push it up.
Right.
Yeah.
Okay.
But this was very
This
convenient.
was convenient, so
Yes.
we did not do that. We forgot only to do
Yeah.
it because everything was seen.
Yeah.
Now, what are the further steps you have to do?
So, ma'am, like you told us, there were two ways in which we can approach this. Either via the UV pouch, like we do for most of our surgeries,
Yes.
or we can do it like we can bisect the bladder. Not bisect exactly.
Bivalve.
Cystotomy,
By,
yeah.
huh.
Cystotomy, we can come
Through
in
the-
between the two
yes.
organs, or we can just enter approach with most of the times urologists prefer to do.
Yeah.
They are
Right.
more well versed with their bladder, so they
Yes.
just cut open
Cut
the
it
bladder
open.
and see the tract from there.
Yeah.
One way, our way is that we go in between
Via
the
the
two
UV pouch,
organs,
yes.
so that the organs are not damaged.
Yes.
So we tried that.
Yeah.
We reached the tract also. We could
Right.
see both
Right.
the surfaces also.
Yes.
But still we felt that the fistulae was very irregular. It
Yeah.
was big and we wanted to see it more clearly.
Right.
So
we
this
changed the
bivalving approach was better.
Huh. So we did not entirely bivalve
No, we
it.
didn't. We didn't.
just made a cystotomy
cut, yes.
Yes.
incision
And freshen the
so
edges.
that we can see the bladder side more clearly.
Yes, ma'am.
Okay. And then we went on dissecting both the
Yeah.
structures. We made them separate.
Yes.
So
Right.
we freshened the edges of both the openings.
yes.
And then what we did,
Mobilized.
we mobilized
Yes, ma'am.
both the organs, and then
Ma'am, the margin, like when we freshened, we created that margin also of about 5 mm. After that, ma'am, now we have to, we catheterized, we placed the, no, first we closed the
Closed
vagina.
it, yeah.
Correct.
so first thing is, so finally what you are doing at what stage, that's totally up to you.
Yes,
Right.
yes.
But one thing, you have to close the vagina. So
Right.
once we close the vagina, one organ is done.
Yes,
so we
ma'am.
close the vagina and then we close the bladder also.
Right, right.
Before, maybe what you wanted to say, that before closing that bladder,
Bladder, we
incision,
had placed the
Placed the
catheter.
catheter.
Yes,
that-
ma'am.
What catheter?
Ma'am, we had placed two, periurethral and this one, the
Suprapubic,
SPC, suprapubic
yeah.
cystostomy.
One
yes.
is urethral catheter
Yes.
and one is suprapubic
Yes,
catheter.
ma'am.
Why do we need to place two catheters here?
Like, ma'am, you had discussed with us, if there's a clot or something that might
Or a
obstruct,
debris,
or
yeah.
debris that might obstruct one of the two. So, since we have two, it's safer.
So what happens when you are doing simple procedures like vaginal hysterectomy in urogynecology? Just one catheter is enough, because that is to drain the urine.
Right.
Right.
And bladder is totally intact. Here, what we are thinking, because there is one big incision line.
Right.
So much trauma has happened. There will be inflammation of tissue. There will be some dead debris. There will be bleeding.
Clots,
so even if one catheter gets blocked
Yeah.
while draining that blood mixed urine, at least the other catheter is there. If by chance you have put only one catheter, what can happen?
That one is
catheter,
blocked.
Blocked and
that
then
same is blocked, and the bladder distends because
Yeah.
of the
And
urine
then
inside.
our
Our
thing
sutures
will
will
give
give
way.
way.
Okay,
and
yes.
it will open. Okay, that's
Yes,
why two
ma'am.
catheter we have put. And one more important thing, we have not directly full bivalving of bladder. We did not
No,
do.
we did not,
Right.
ma'am.
Why
Yes,
we
ma'am.
did not do?
Why did we not do it?
Yes.
That would reduce the capacity of the
Even
bladder
more.
even
So
more.
you have to remember for 5 years,
Yeah.
her detrusor is totally inactive. It is collapsed.
Right.
So the bladder capacity, see whether it is mind, whether it is body, whether it is bladder. When they keep on working, they are
They'll
active
be in
and
that
they
good
are
condition.
in that tone.
Right.
Yes, ma'am.
Now the bladder has lost its tone because for 5 years it has forgotten how it fills. Okay, so bladder capacity, if we saw, it was already reduced.
Okay.
Then if we give big incision and then suture, little tissue goes in that suture line also.
Yes,
Right,
ma'am.
yes, ma'am.
Okay, so bladder capacity will decrease even further.
Okay.
That was the reason that we were planning initially to go in
Via
between,
in
two
between
organs
the two
and not
organs.
disturb bladder that much,
Okay.
so that we do not decrease the capacity.
Ma'am, I also thought that we already achieved a very good margin within, and that's why we probably didn't go further. And yeah.
So we did not plan. Usually when people do, some of the people, first thing they do is
Just
they
cut
take
it
the
open.
scissors and cut
Cut
the
it
bladder
open.
open.
Yeah.
But we were very careful. We
Yeah.
want this as minimum incision,
Yes.
Right.
so that only exposure is there and nice closure we can do. But we did not want to do too much of opening of bladder,
Yes.
because whatever
That
opening
would
we
have
have to
got-
suture
yes.
it back. That will again reduce
reduce the
capacity
volume.
of the
Okay,
bladder.
okay, ma'am.
Okay. So then we did both the things.
Yes.
And after doing those two closure,
Yes, ma'am.
okay, with a good margin,
Yes.
what you have to do after that, what did we do?
So, ma'am, the closure had this important point that you told us about the perpendicular thing. That
So
yes.
this is about, now you have to remember that whenever there is fistula, any
Yes,
kind
any.
of fistula, they have a very high risk of recurrence.
Recurrence.
Yes,
Because
true.
there is something flowing continuously there.
Right, ma'am.
Okay, and the other thing is, once they have got attached to each other, they
Yeah.
get the affinity to
Right.
attach again.
Yeah.
So we have to do things so that we can prevent recurrence. We have to try our level best.
Best. Yes.
Still it can recur.
True, true.
Okay, but now let's discuss what are the things you do to prevent the recurrence.
So, what we had done, ma'am, was that we had closed both of these things in different directions. Like our vagina, we had closed it vertically.
Right.
And the bladder, we had closed in a transverse fashion. So, the point of contact was just one, if
One.
at all. Second thing,
So if you do two same line, there is
Yes.
lot of point of contact, and anywhere little inflammation, little addition,
Yeah.
it can just
Reform
connect
the
Reconnect
tract.
again.
reconnect
Yeah.
again and
yes,
reform
the
the
tract. Yes.
So when we do it perpendicular, the point of contact is
It's so
bare minimum.
Yes, ma'am.
Okay. So chance of recurrence is less.
Hmm.
Second thing, you have before only told that we have to have a nice margin around.
Yes,
So
ma'am.
that the organs are separate. If little bit you do, maybe that suture line is separate from each other, but the
Yeah.
organs are too close to each
True,
other.
true, Right. true.
Okay. So we have to mobilize them. We have to say
Mobilize
you are
properly.
different, you are different. Clear
Yeah.
margin or around
Yeah.
suture in different direction. Then what last?
The flap.
Omental flap.
Omental
Flap. So you have to bring the omentum down.
Hmm.
In this lady, her good luck that omentum was very,
Very
nice,
nice,
flowing.
Yes.
and we could without any
It was
Tension,
quite easy
yes,
to bring it down.
yes.
Right.
Suppose in some of the patients,
Hmm.
the omentum won't be that much mobile. Patient will be big. So it should not be under tension, because
Right,
then
ma'am.
it will create tension on the colon. Transverse colon will
Yeah.
always be at the
Right, okay.
tension.
Yeah.
So you have to sometimes give an
Cut
incision
it
in
open.
between,
Hmm.
make it a tongue-shaped structure,
Bring
and
that
bring
down.
it down.
Right.
Okay, that also is it. Suppose in some cases, I'm deviating from the topic a little bit. Suppose it is not a case of clean-cut fistula; it is post-radiation fistula.
Okay.
After some cervical cancer, and patient has come
Right.
to you,
Yes, ma'am.
and the omentum is totally adhered. It is
Yeah.
not coming down.
Right.
In that, do we have something else which we can?
The peritoneum.
Peritoneum.
Yes.
That UV fold peritoneum, we can dissect it from entire part and,
And
bring it down,
down.
and put some sutures.
Right.
There are some kind of fibrin glues also available
Okay.
there. Many laparoscopic surgeons these
Use
days
those.
just use the glue.
Glue,
So
okay.
you
Not the
just have to
omentum or peritoneum
load the
at all,
omentum,
ma'am. Okay.
because it creates a layer in between.
All right.
Actually, maybe, I don't know, thing just came to my mind.
Huh.
Maybe something like interseed also, which we
Interseed.
use.
It's like a
Okay.
barrier for the
Barrier,
myoma.
Okay.
myoma,
Ah.
we put it. Maybe that also can be
Can be
sutured.
right.
Okay.
Okay.
But omentum is the best.
Yes, ma'am.
Okay.
Right.
And
I
natural.
think natural and
Yeah.
with good blood supply always. Blood
Yes.
supply is very,
Very
Very
good,
important.
very vascular.
So I think if you have omentum, nothing like omentum.
Yes, ma'am.
One more thing, when we are talking about these flaps,
Yeah.
see small vesicovaginal fistula
Okay.
and lower down vesicovaginal
Okay.
fistula, the approach should be different. Now we are discussing laparoscopic and open
Open,
abdominal.
yes.
What
Yeah.
is the third technique?
Vaginal.
Vaginal.
Yes.
Okay.
Yes.
So vaginal surgeries also can be done, but for that the fistula has to be lower down.
Yes,
Right.
ma'am,
Okay,
absolutely.
first criteria is
access.
To
lower down.
access,
Yes.
yeah,
Because,
exactly.
because if you open the abdomen for a fistula which is very low down, it
You're
becomes
making
even
it
more difficult.
even harder. Yes, ma'am.
yes.
So these fistula, and if the size is big, or if it is a recurrent fistula,
Yeah.
you want to put something in between there.
Yeah.
You cannot bring the omentum from up. Then
Yes.
what do you use?
You can't.
Something you have
Maybe.
to use.
Okay.
The mucosa, the vaginal, no. Give us a hint, ma'am.
Some fat surrounding there, omental fat you are using. Here
Labial
also-
fat.
Labial
fat, okay.
So you take a flap, you make a flap from labia majora.
Okay.
Bring it inside the labia minora with intact blood supply.
Okay.
It is called Marsh's flap.
Marsh's
Marsh's flap.
yeah,
Yes,
Okay.
ma'am.
So you interpose in between that.
Okay.
Fat. We will not be discussing much about vaginal approach because even what we did is too much to
Isn't-
discuss.
yeah,
we don't want to
right.
make it
Yeah.
very lengthy
Long,
discussion.
yes, ma'am.
So after that, after we diagnosed, then what else we did after completion? We have put two catheter, we have put a omental graft in
Yeah.
between, omental patch in between.
Yes.
Then at the end, we check something.
Ma'am, we checked for the water tightness
Water
of the closure.
tightness of the
Closure.
bladder side.
Yes.
Vagina doesn't matter.
Obviously,
Right.
Yeah.
But vagina, one thing if you remember, we were testing in between.
Yes, ma'am. The
Patency of
patency.
vagina.
Yeah.
Patency.
While we were
Right.
suturing, we'd place the finger.
We shouldn't
There
close
on.
it.
Yes.
Yes.
Otherwise, patient will come with hematometra.
Right.
Okay. So now this we have checked.
Hmm.
Now is the time to check the patency of the like the water tightness, as you correctly said,
Yeah.
of the bladder.
Yes,
So
ma'am.
how do we check it, Supriti?
So, ma'am, we use the methylene blue test. We do retrograde filling of the bladder. In this case, ma'am, like you told us, that we tried our best that we do not compromise with the already very less volume that the patient
Yes.
had. So, one thing we did was that we did not bivalve it completely,
Yes.
and we did a single closure, the single
yes.
lead closure. So, again, ma'am, we didn't have to fill it up like we do in a normal patient with that much volume, but we filled it up only with about 50 ml.
Yes. So I'll tell you what Supriti is trying to tell. Maybe we have discussed it.
Yeah.
Right.
Sometime. So there can be two conditions. One condition where I'm doing a surgery. Suppose a TLH or a hysterectomy for a patient who has already undergone 2 to 3 cesareans. Or
Yeah.
maybe a cesarean for a lady who has already undergone 2 cesarean.
Yes.
And bladder dissection was difficult.
Yeah.
I did a
Sharp
sharp bladder
dissection.
dissection. And I am worried that somewhere either I have weakened the serosa or
Yeah.
injured the bladder. There is
Right.
no leakage of urine.
Yeah.
But I am worried.
Want
I
to
want
make
to
sure.
check it so that I can sleep peacefully in the night.
Absolutely.
Right.
In those kind of patient, when we fill the bladder, just for the sake of checking it, I am not sure, plus or minus 90% maybe I'm sure no injury, but I want to be 100%
100%
sure.
sure.
ma'am.
In those women, we fill the bladder depending on their size, 200 to 250 ml
Yes,
of
ma'am.
Methylene blue.
Methylene blue.
But here, as you said, Subriti,
Yeah.
correctly, the bladder capacity is already,
already
small.
low. Yeah.
And if we put 200 ml,
We
bladder
are going
will
to
just
break it open.
Right.
Yes.
Okay, again.
Yeah.
So all our effort will be lost.
Yes,
So
ma'am.
slowly we fill. With 50 ml only, we
Yeah.
could see that bladder was filling
Yeah.
and the area was getting stained and little bit was coming. Actually, it was not perfectly watertight.
Yeah.
But we did single layer closure. If
Yes.
given in any other patient, I would have preferred to do it
Do a
two-layer
double layer closure.
But actually, single layer has been recommended now.
Yes.
With
Like integrity is not compromised.
Yes.
compromised. But here we had one more reason we did not want to do it double layer.
Yeah.
Because it will further compromise
Nice.
on
On
the
the volume.
capacity.
Yes, capacity.
Or the volume of the bladder. So we chose to do it single layer by choice.
Yes,
Not
ma'am.
to save time, but to save the capacity of the
Capacity,
bladder
yes.
as much as. Because our idea is patient came with incontinence.
Right.
She came with continuous incontinence. If we decrease the capacity too much, she goes back and she again has incontinence. What
Yes.
kind of incontinence?
If
Urgent
Urgent
incontinence.
incontinence.
Yes, ma'am.
Previously, she was leaking without the feeling of urgency, that
Yeah.
bothersome feeling. Now she
Now
will
she'll
leak
come back with
because of
urgency.
So actually, we have worsened her life.
Right.
Yeah.
That should not be
because
the
it will fill
idea.
too quickly, ma'am. That's what you
Yes,
mean, right?
Bladder
Yeah.
will contract every
Yeah.
time. Bladder wall is now contracting.
Yes.
Okay, and little bit it fills. Bladder has no space to
Like expand
expand.
further.
She will go. So we are sending her with. She came to us with continuous dribble, which was tolerable. At least she did not have pain and bad feeling of
She didn't have
urgency.
yes, ma'am.
Okay. Now she goes back again with incontinence, with a horrible feeling of,
Of
urgency,
urgency.
and pain in her bladder. We should not do. We should try,
We try to help
avoid
that.
it.
Yes.
Okay. Now after that, abdomen was closed.
Yes,
One
ma'am.
drain also we put.
We have put,
Intra-abdominal drain.
Why drain?
Ma'am, we have put the drain because if there is any leak, then we'll get to know. And also, if there is any contamination, it will drain out through that.
Yes.
So peritonitis or anything like that will
Will
not
not
occur.
happen. Okay, so we have put a drain also. Now there are two catheters.
Yes.
One is drain. When
Yeah.
it starts having less volume, actually less than 50, you can remove that drain.
Right.
When
Yes.
patient is ambulating, you can remove. Now there are two catheters. One is in the urethra, one is suprapubic. Which one do you want to remove first and when?
So, ma'am, we want to remove the SPC first.
SPC first.
Yeah. And by about maybe a week or two, we can remove it. And so I have a doubt here, ma'am. Like, I think maybe we remove it first and keep the urethral one for longer because that is the physiological passage.
And we'll give
Maybe
this time.
I will give
Yeah,
Veera
you-
this question.
Yes.
So she said, correct. I totally agree to Subriti's answer that first we have to
Remove the SPC.
SPC,
Yes.
suprapubic catheter.
Yeah.
Okay, why?
So that after we remove the suprapubic catheter, we still have an upper urethral catheter still in situ. So our bladder would still be draining and give even that small opening
It
of
will
the
heal.
SPC to
It
heal.
will heal.
Yes,
It
yeah.
will heal.
So bladder is still contracted.
Yeah.
If we leave the bladder without any catheter draining it, it will go into phases of contraction
Yeah.
and distension, contraction and distension. And if SPC is removed today and their patient goes into this process of expansion and contraction, this tract will never heal.
Right.
Okay. So what we did, we removed this catheter. There is a small tract, few millimeters tract,
Yeah.
and still bladder is at rest, contracted for 2 more weeks, 3 more
Yes,
weeks.
because we have the
area
urethral.
will-
Yes,
urethral
yes,
catheter,
yes.
that area will heal.
Yeah.
Okay, so depending on how well both the catheters are draining,
Yeah.
as you correctly said, I will remove the catheter, first catheter in 7 to 10 days,
Yes.
and the second catheter after maybe
3 to
3
4
weeks. 3 to 4
weeks.
weeks.
Yes, ma'am.
And same time when the patient comes for next visit, you have to remember that urethral catheters also to be removed.
Yes,
Right.
yes, ma'am.
Okay,
Yes.
because we have put it, we have not removed it. Actually, we could have removed it immediately after surgery
Yeah.
also, but they were there. Why they were there? Because still after our dissection, we were very close to trigone.
Yeah.
So fibrosis or anything
So
else
many factors.
should not contract.
Or
or
they
should
close
not
the
close
urethra.
Stricture or close that.
stricture or
Right.
contracture of this thing. So we have kept it. Once she comes after 3 weeks,
Yeah, to ensure the
we call
patency
out.
means. Okay.
So because we were very close, we were working
Yes,
very
ma'am.
close
Very
to the
close,
trigone and
especially the
urethral
left
orifices.
side.
Oh, yeah.
Especially the left.
Okay, so this time when she comes, we can remove everything together.
Yes.
Okay, then any other advice you want to give to your patient in post-operative period? This is about catheter. What
Yeah.
about other management?
So in the post-operative period, one, yeah, like you said, ma'am, prolonged catheterization.
Catheter over.
Over.
Any
And
medication, any
medication.
other thing you want to give?
So, ma'am, we gave her solifenacin to ensure that
To relax.
No,
Yeah,
relax,
actually,
relax.
yeah.
For the bladder
Bladder
muscle.
muscle, huh.
One thing is it should not go into spasm.
Yeah,
okay?
to prevent
It has
spasms.
to take rest. And when you have put sutures, see,
Yeah.
bladder is an organ, okay?
Yeah.
If you have sutures, if you have so many foreign bodies, one catheter from here, one catheter, you have handled it so much, it is irritated.
Yes.
That irritated feeling, the brain will perceive, okay?
Yeah.
So there will be urgency for the patient. So we
Okay.
want it to remain cool and calm and patient till the catheters are there.
Okay.
Okay, and maybe it will help a little bit to relax the muscles so that detrusor learns to relax because it has
Okay.
forgotten to relax for 5 years.
Right.
Okay.
So what is the dose?
For this one, solifenacin, ma'am, it is
5 milligrams
BD.
BD.
Yeah.
Yes.
Okay, we are sending her on that. If you feel if the patient complains of again urgency, we can add something. We can add mirabegron
Yes,
also
ma'am.
with this so that she has a combined effect. 2 drugs can be added together. We'll see if after
When she
while-
comes for a review, yeah.
or while we are discharging her.
Yes,
okay, if
ma'am.
we discharge after removing a catheter, we'll see how she's behaving. If she feels pain, urgency, or any that
Maybe
kind
we
of
can
symptoms, maybe we can add and
Yes,
send it
ma'am.
home. So this is the entire plan for this patient. I hope the patient will recover well.
Yes, we
and
all
will
hope
get
so.
a good
Yes, ma'am.
outcome.
Yes.
And will be able to make a little change but relieve the suffering of this lady.
Right.
And I don't know how many women are suffering out there like this. The incidence, what we are seeing is really the tip of the iceberg.
Yes, ma'am.
Okay, so you ask if a patient comes with urinary problem, take a good history, ask your patient, take her obstetric history, ask her when the symptoms started. Don't just treat UTI
Yeah.
and send her back. Don't
Right.
We
say
should
that
take
it
a
is a
very
part and
thorough,
parcel.
detailed
Yes.
history.
And if you cannot take, it's okay. Everybody cannot do. Please at least refer her to a person who can do that for you. That's our request with this case discussion. Felt very pathetic. I hope she recovers.
Yes, ma'am, she will.
She will recover.
Yes,
I
ma'am.
hope so. So let's hope for the best. And
Yeah.
with this, we'll finish today's discussion. Thank you so
Thank
much.
you.
Bye.
Thank you so much.
Now, let me give you some bullet points on the surgical management of vesicovaginal fistula and its postoperative care, what we discussed today. So, first thing is the approach. Approach or repair of VVF can be either abdominal or vaginal. In abdominal, it can be open abdominal method, laparoscopy, or even robotic approach, depending upon what is your preference. In cases like this, where the fistula is high and it is large in size, abdominal approach is a better option. Preoperative catheterization of ureters is a good practice point. Transverse incision always gives an excellent exposure as the organs of interest, both the organs of interest, lie in the pelvis. Prevention of recurrence should be kept in mind, and to achieve that, you must dissect a good margin. Again, followed by good approximation of the organs. The suture line preferably should be perpendicular to each other and keeping an omental patch in between the two suture lines will definitely prevent recurrence and facilitate good healing. One practical point I would like to point out here is that in cases of long-standing fistula, do not over-distend bladder with lot of methylene blue as we do in cases where we are just checking it prophylactically. 50 to 100 ml is more than enough. We always keep two catheters, one from the urethra and one suprapubic in the bladder to ensure continuous bladder drainage. When it comes to removal, SPC has to be removed first, followed by the urethral catheter. Keep the bladder empty and relaxed and post-operative period to ensure good healing. I hope these kind of discussions are helping you to gain some little extra practical points for your clinical practice and also for your understanding of the concepts. Let me know if you feel like asking any other question. Please post it in the comment box below. Thank you so much.